Dear committee, dear audience, as the last candidate from the dentistry group, I would also like to welcome you all in our 3-month progress report. So please allow me to present my PhD topic about the prosthodontic perspective of mandibular reconstruction methodologies. I am now Zsófia Tasi, a 5th-year dental student and also an MD PhD student at the Translational Medicine program. My vision is that patients undergoing mandibular reconstruction receive the best possible dental prosthesis. And in order to achieve that, I would like to provide evidence-based guidelines that optimize those mandibular reconstruction methodologies. For now, I have 2 specific goals, and they are connected to each other because they are both related to the treatment of head and neck cancer patients. And the first one is about the investigation of the success rate and safety of primary and secondary implantation in patients undergoing mandibular reconstruction. So first of all, let's see a definition. So what do we mean by mandibular reconstruction? This is basically the replacement of a missing mandibular segment with different kind of autografts, such as the fibula bone or the iliac crest. And the most prominent need and the indication of these surgeries is the presence of a huge cancerous or sometimes also radionecrotic lesion. And if we do not recover the dimension, the arch of the mandible, and also the oral function of our patients, we can imagine how badly it can affect both aesthetics and functionality. So basically, this is what makes crucial for the rehabilitation to be completed as quickly and also as accurate as possible, because we would like to ensure that our patients spend only a short period of time under these really compromised life quality conditions. So, just a few more words about the whole rehabilitation process. Basically, when we are doing the implantation, we can choose between 2 options. Either we do a primary or immediate reconstruction and implantation, which means that we have one single operation for doing the reconstruction and also to place the implant into this grafted bone. And on the other hand, we have secondary or delayed version when we have 2 surgeries, one for the reconstruction and then other surgery after a healing period when we are placing the implants. So, of course, each method has pros and cons, but just for summarizing it a little bit more, since primary implantation means one single operation, the whole recovery becomes faster. And another beneficial point could be that osseointegration can start before the postoperative irradiation. And on the other hand, secondary implantation might provide a safer surgical outcome, and it's easier to achieve with it an optimal implant placement. But of course, we need 2 operations, and the whole recovery is longer. And there is a longer interim period without functional teeth, and it can impact, of course, the oral health, nutritional status of our patients. So we would like to provide evidence that primary implantation can be chosen whenever it is possible, because it is safe and it enhances the quality of life of the head and neck cancer patients. So here you can see the clinical question about the timing of implantation. And we would like to compare primary implantation to secondary implantation. And this outcome, we have the survival rate of implants and also the implant-related and patient-related complications. And here we are. So what is the clinical implication? So this is basically the most important question. If we could choose primary implantation over secondary one, then we could reduce, of course, the treatment time of our patients and therefore improve the patient's outcome as soon as possible. And we have got more than 11,000 hits after the duplicate removal. So now I am at the stage of title and abstract selection. Hopefully I will finish it until next week, so we can move on to the full text selection. And the second topic is about the investigation of the safety and effectiveness of hydrophilic and hydrophobic implant surfaces in irradiated jaws. So head and neck cancer is reported the 7th most common cancer diagnosis annually, and up to 85% of the patients receive some sort of radiotherapy. And it is extremely important to take into account the fact of irradiation when we are planning the dental rehabilitation of our patients, because we usually use implantation to restore the function and aesthetics and to improve the overall quality of life. But of course, the success of implantation can be based on many different factors, such as the bone quality and density, which is, of course, negatively influenced by radiotherapy, and also the surgical technique we use and the implant characteristics. And among these factors, we are planning to concentrate on the surface characteristics because they are one of the most developed features of the implants, and because they also have a crucial role in osseointegration. And osseointegration is like an indicator of a successful implantation. And due to its important role, multiple implant surface types have emerged in the past few years. But basically, we can divide them into two main groups, hydrophobic and hydrophilic ones. And for now, surgeons use all kinds of implants, but one of the drawbacks of hydrophobic ones is that they provide a slower osseointegration. So hydrophilic implant surface provides a better cell adhesion, and therefore the whole osseointegration becomes faster, and it can be really beneficial when we are talking about an irradiated bone where the healing situations are really compromised. So we would like to explore how these implant surface characteristics affect the outcomes in irradiated bones, because there are data available of how the implant surface influences the outcomes in normal jaw bones, but there isn't such summary concerning irradiated jaws. So the clinical question is that what are the differences in success and complication if we compare hydrophilic and hydrophobic implant surfaces in irradiated jaws? And the clinical and the research implication is that if you could identify surface types with higher success rates, then we could optimize dental rehabilitation in head and neck cancer patients even after irradiation. And so this is just the summary of our two projects with the planned submission date. And I would also like to end my presentation with a quote from Katalin Karikó, who is a great inspiration to me, and who once said that if everything is always handed to you, if the red carpet is rolled out for you, then you never learn how to fight. Thank you.
Firstly, I would like to congratulate you for the presentation. This is a very wide and complex topic, but your presentation was very well structured and straightforward. So my question would be, which bone graft do you consider to be the best, and what would be the advantages and disadvantages on regarding the clinical use?
Thank you for your question. So basically, the fibula bone is considered the gold standard for these reconstruction techniques in the maxillofacial area because it has a really good blood supply, and also the bone quality and density is quite good. So we can use it safely. And another beneficial point can be that there is a triangular cross-section of the fibula bone, so maybe it's easier to adapt it into this maxillofacial area.
Okay, thank you very much.
Congratulations. And my question is regarding to your first project, that is implant prostheses are the only option for the dental rehabilitation for the head and neck cancer patients?
Theoretically, no. So we can use also conventional prostheses for our patients, but to be honest, we prefer the implant-supported prostheses because the conventional ones are discomfortable for the patients, and sometimes so we usually talk about irradiated patients also, and therefore the side effect of irradiations or chemotherapy, such as mucositis, can lead to really uncomfortable situations when patients are wearing conventional prostheses.
Thank you.
Congratulations to your presentation. It was very interesting. I have a question for the first project as well. So I was wondering, doesn't the patients with the one operation method have maybe more complication afterwards because we irradiate an implantation? Aren't they losing it in the end?
So sorry. So you mentioned that the primary one has more, or
yes. So if you irradiate after you put in the implantation, is under a higher risk for more complications?
Yes, so basically we do not like to put implants into an irradiated bone. And that's why, for example, primary implantation can be a better option for the patients, because if the implants are placed simultaneously, then we do the reconstruction, then it has a little bit time, so it can be placed into a normal bone, and the postoperative irradiation can start after it. So the outcome would be better than at the secondary implantation.
Okay, thank you.
Thank you.
Is it working? Okay. Thank you for your presentation. It was nice. I was wondering about the hydrophilic surface treatment and about the bone implant contact. Could you please be more specific and explain how those treatments improve the bone implant contact? Yeah.
So basically, we prefer hydrophilic implant surfaces because they have a water-attracting surface which can provide the cell adhesion, the adhesion of osteoblasts into this implant, and also the adhesion of proteins. So therefore, the whole recovery, the osseointegration can be a little bit faster than so compared to a hydrophobic implant surface. So this is why we prefer those newer hydrophilic implants.
Thank you for your answer.
Thank you very much. I also have a question regarding hydrophilicity. How do you measure it?
How do I measure the hydrophilicity? Well, so it basically, we do not need to measure the hydrophilicity. We would like to investigate the success. So we know that there are different types of implants, hydrophobic and hydrophilic ones. So this is basically...
How do you make the distinction?
So this is a question of the treatment methods, how it is made, so how implants are made. And for example, if I can go back. So hydrophobic ones are the sandblasted, acid-edged, etc. implants. Those are the ones that we call hydrophobic ones. And there are other types of...
Are you calling it hydrophobic or...?
No. So it's now
I would urge you to rethink this, because there are no hydrophobic implant surfaces, because just as you said, osseointegration would not be possible with a hydrophobic implant surface. So if you want to do a secondary research like this, you have to look at the grades of hydrophilicity, because if you look at this, if you look at brands, if you look at surfaces, you will see that all surface implants, they also integrate, they are capable of integration, and so they do it in like more than 99% of the cases.
Maybe this is just the way we call them, because the newer hydrophilic ones are so much different. So
they are more hydrophilic.
Maybe
I just suggest that you call them
less
so that's and more hydrophilic
point, of course.
And find the literature on it, what you can base this assumption on.
Okay, thank you.
Thank you.